Welcome to the online symposium, Does Atherosclerosis Have a Sex and Gender? Perspectives from Basic Science to Clinical Practice. The session will start in a few seconds.
Good afternoon, everybody. On behalf of the European Society of Cardiology, I welcome you to this, which is on the role of sex and gender on atherosclerosis. This is a joint activity of the ESC Council for Basic Science, and I'm representing that council, and also the Working Group for Atherosclerosis and Vascular Biology. And this is represented by Marie-Luce, Bochaton-Piallat, and Elena Osto. So firstly, I'd like to thank Marie-Luce and Elena for all their hard work in organising this meeting. It promises to be a fascinating session. So just for the first 2 minutes, I want to talk about some of the activities of the Council, especially those for our early career researchers. And firstly, I want to thank and acknowledge my colleagues on the nucleus who've organised everything that I'm going to talk about today. So we're led by Christian Weber, he's our chair. Hans Witter is our chair-elect. Johannes Waltenberger is our past chair. And Imo Hoffer is our treasurer, so he looks after the cash. So now moving to some of our activities and related to the treasury and the money, we have a number of awards and fellowships. These include a basic research fellowship, and this allows researchers to spend a year at a European lab. So this is really great for new collaborations, learning new techniques, and starting initiating new fellowship applications, for example. And we also have some shorter term mobility grants as well. And these are really great opportunities for our early career researchers. We also have a group dedicated to early careers called the Scientists of Tomorrow. They have around 1,200 members, and they're very active in terms of writing papers and organising sessions. So what else do we do? Well, we also organise a basic science summer school for our early career researchers every 2 years. So the next one is in 2023, organised by Gemma Villaher and Pina Caliuri. It's going to be some really great science. And also in the afternoons, you can relax on the beach on the French Riviera, having a bottle of wine or a glass of wine and some lovely cheese and fruit. So it sounds like a fantastic opportunity. So please put that in your diaries. And then finally, I want to talk about our flagship meeting. This is the Frontiers in Cardiovascular Biomedicine, or FCVB. The next one is next year from 29th of April to the 1st of May. And it's in Budapest, a very exciting city. And I've looked at the programme for FCVB 2022. It looks really amazing. So please start writing your abstracts and start registering for that meeting. It's going to be fabulous. Now, I've had to be very quick, but we have a lot of things going on. You can find details in the website shown below. And joining the council and joining the Scientists of Tomorrow is completely free. And there's, as I said, a lot of activities. So now it just leaves me to hand over to Elena Osto, and Elena is going to chair the scientific part of the meeting and introduce the first speaker. So Elena,
thank you. Thank you, Paul. Thank you. Good evening also from my side. It's a real pleasure to be with so many participants and such excellent speakers. So now, without further ado, let me introduce the first speaker, Professor Noel Berry-Merz from Barbara Streisand Women's Heart Center, Cedars-Sinai Smith Heart Institute, Los Angeles, California, US. And she will talk about sex differences and the heart, coronary microvascular dysfunction. Please.
Thank you, Professor Elena. Sex differences and the heart, coronary microvascular dysfunction. These are my disclosures, which are grant support. So we embarked on our studies of women and heart disease due to alarming trends in the United States, where in 1984, women became the majority of victims of cardiovascular disease deaths. In the 1990s, the Yentl movie came out, and I will describe the Yentl syndrome, where women are not recognized as having cardiovascular disease. And 12 years later, our Women's Ischemia Syndrome evaluation, sponsored by the National Heart, Lung, and Blood Institute, as well as our American Heart Association, began initiatives to address this epidemic of cardiovascular disease death. The Yentl syndrome, of course, was coined by Dr. Bernadine Healy, shown here on the left side of your screen, and taking the term from the, at that time, Yentl movie, starring, directed, and produced by Barbra Streisand, shown on the right, which told the story, of course, in Eastern Europe in turn of the century, where women were not allowed to learn to become literate. And of course, Barbara starred in that movie where she impersonated a man in order to have the same rights and privileges of men. We embarked on now an over 30-year study called the Women's Ischemia Syndrome Evaluation. We have been able to describe sex differences in heart attack plaques, working with our pathologists at the Uniformed Health Services Medical Center. We demonstrated that women are much more likely to have plaque erosion, which results in relatively smaller heart attacks with distal embolization, where men were more likely to rupture that fibrous cap and have explosions, which result more often in the ST segment elevation MIs that are more easily recognized. We also, using intravascular ultrasound, described differing patterns in terms of how the atherosclerotic plaque was distributed in the epicardial coronary arteries, where panel A on top is a more male pattern with lumpy, bumpy obstructive disease, perhaps similar to how men become obese focally in the visceral fat, or we call it a beer belly in the United States. Female pattern, more diffuse, in the coronary artery tree, perhaps reminiscent of how women gain weight, which is that subcutaneous cellulite. Nevertheless, we demonstrated that both of these patterns were consistent with developing ischemia, demonstrated by pressure drops across the coronary arteries. So we described a male pattern of obstructive coronary disease, more prevalent, accounts for 90% of coronary artery disease in men, where female pattern, coined now microvascular coronary dysfunction, relatively more prevalent and probably accounts for over 25% of ischemic heart disease deaths, as well as morbidity in women. We also have demonstrated that these patterns can be consistent with an abnormal SPECT. It can also be demonstrated by abnormal flow reserves, as seen here in panel C. It is concomitant with often an elevated left ventricular end diastolic filling pressure in the absence, of course, of heart failure or valve dysfunction. And panel B demonstrates the often diffuse atherosclerosis. Using our investigators as well as cost analysts, we've estimated that there are 3 million women in the United States. So, of course, an equal number throughout the world, throughout Europe, placing this as a larger problem than breast cancer. We've also, on the right, now designed new terminology you are seeing in the literature: ischemia with no obstructive coronary disease, INOCA, as well as myocardial infarction with no obstructive CAD, MINOCA. Well, we have continued to publish, and we, as well as European colleagues, now demonstrate that while obstructive coronary disease, a male pattern easily recognized, demonstrated here with Barbara Streisand in her movie Dressed Up Like a Man, is not as recognized when women present as female pattern microvascular. It does not show up easily on an angiogram. And this, of course, then results in not being recognized, means you do not get treated with these life-saving therapies after an ACS, after an NSTEMI or STEMI of low-dose aspirin, beta blocker, ACE, and statin. And these observational population studies clearly demonstrated that the surplus of death being demonstrated in women, the epidemic of death that we described at the beginning, was most likely due to this microvascular pattern. Now, we've continued to look at this, and of course, multiple mechanisms of myocardial ischemia, including INOCA, are depicted in this diagram. Atherosclerotic coronary disease is well known and well treated at this point. Vasospastic disease in the middle accounts for a relatively small, probably less than 5% of ischemic heart disease. This might sometimes be called Prince-Metal's angina. So the coronary microcirculation is the sort of dark side of the moon at this point, but it is very clearly contributing. And it is also well understood now that these three mechanisms can overlap. It is not an either-or situation. We demonstrate this on either cardiac MRI or PET scanning, and you can see with the persistent dark rim here, the cardiac MRI demonstrating microvascular coronary dysfunction. So we are now able to diagnose this non-invasively in addition to invasively. We've demonstrated that women with signs and symptoms of ischemia, no obstructive coronary disease, but most often coronary atherosclerosis, that impaired microvascular dilation is a poor prognostic predictor and predicts adverse cardiovascular events, non-fatal MI, non-fatal stroke, development of heart failure, as well as mortality. Increased epicardial coronary constriction, however, predicts angina hospitalization. So the impaired flow reserve is actually the riskier of these opportunities. And this, of course, was determined by invasive testing because the constriction cannot be tested non-invasively. We've done a number of coronary microvascular randomized pharmacologic probe trials. And you can see here that ACE inhibitors improve coronary flow reserve. And this was also shown by other investigators with statin therapy. However, hormones, eplerenone, sildenafil, and ranolazine don't really improve coronary flow reserve. And these pharmacologic probe trials were done, placebo-controlled, in order to identify pathways to design and develop large MACE trials, which we are conducting now, called the Warrior Women's Ischemia Treatment, reduces events in non-obstructive coronary disease. The investigators are as listed there. This randomized controlled strategy trial is randomizing 4,422 subjects with angina and no obstructive coronary disease, randomized to intensive statin therapy as well as maximally tolerated ACE or ARB versus guideline primary care risk factor management or usual care for the reduction of MACE, which includes all-cause death, non-fatal MI, non-fatal stroke, or hospitalization for angina or heart failure. We are in the midst of this trial at this time, so we will have to revisit this in 2 to 3 years. So what's happened since we've been doing this work? Well, in fact, in the United States, we have demonstrated a 43% drop in the first decade of research as well as our guidelines campaigns. And what's happened subsequently? Well, we've done a pretty darn good job. The question now is, Are these deaths demonstrated in red compared to men in blue optimal for women? Might this be a better mark for women, given our history of women historically doing somewhat better than men in terms of cardiovascular disease? So I will end there. Thank you so much for inviting me and sharing our research, our good progress, but more needs to happen. Thank you.
Thank you so much. Now I think we can accommodate a couple of questions, but first I also ask them to share in case they have questions. Meanwhile, that also our audience can type in their burning questions.
Okay, so maybe Elena
Please,
can ask a question. Okay,
please, Marie-Luce.
Thank you so much for the great presentation. An honor having you on this stage. Is there any relationship between the erosion plaques that are typical of women with smoking? What is the effect of smoking? Thank you.
Yes, and in our data, women smoke relatively less than men, and while women have caught up in the modern age, and our younger women in the United States are starting to smoke, they say for weight management. So we're seeing, unfortunately, a surge in cigarette smoking. And yet that did not appear to explain the variation in what we were seeing. So I think there probably is some basic science biology that is different in how women and men, one of the phrases that we term for our community is how women and men put the garbage away. And fat deposition appears to be different, not only in our viscera and our subcutaneous, but our coronary arteries.
Thank you.
Do we have other questions? I see
have
that
a question.
Paul wants to ask something. Please, Paul.
Yes, and I would also encourage people to please send their questions into the Q&A, and let's get this discussion moving. My question's about the very start. You talked about men have disease. I wonder whether do you think that's a hemodynamic difference? I know Dr. Wenzel later is going to talk about hemodynamics, but I wondered if you have a view on that.
Yes, I think that it potentially is. Even adjusted for body surface area, women have relatively smaller coronary arteries than men. And this is further supported that this is a true teleologic difference by our transplant literature, where when we take a female heart and transplant it into a male body, the coronary arteries enlarge to match the BSA of the recipient. Conversely, it doesn't go. So if a male heart goes into a female body, the arteries do not get smaller. The best explanation for this is probably testosterone and or other endogenous hormones, but it really makes the case that men with relatively larger arteries at the get-go likely have a different hemodynamic pulsatile perhaps risk for more, we know that plaque forms in areas of turbulence, and higher flow potentially would be more turbulent at those areas. So I think your hypothesis would be something that is probably we could validate with some basic science.
Thank you very much.
Thank you so much. And now we move to the second distinguished speaker, that is Professor Alexandra Kauzi-Willer from the Gender Medicine Unit, University of Vienna, Austria. And she will talk and ask us a question. So the question is, towards a gender-specific cardiovascular prevention. Please, Alexandra, the stage is yours.
Hello. Yeah, thank you for the invitation to share some thoughts about prevention. So 70% of cardiovascular diseases and deaths are attributable to modifiable risk factors, and especially in high-income countries, the pink and the gray bars on the right side refer to metabolic risk factors and behavioral risk factors, so it's the biggest part. Hypertension, dysglycemia, non-HDL cholesterol, and abdominal obesity, as well as smoking, alcohol consumption, diet quality, physical activity, and sodium intake. And here you can see the risk factors related to the global number of deaths by cause and sex. And again, the greatest part is due to cardiovascular diseases. And the leading risk factors differ somewhat between the sexes. In women, we have number 1, high systolic blood pressure, followed by dietary risk, high fasting plasma glucose, and number 5, higher body mass index. In men, number 1 is still smoking, followed by high systolic blood pressure, dietary risk, and number 5, high fasting plasma glucose. So the risk factors represent the metabolic syndrome and therefore confirm older studies, the Interheart study, for example, where metabolic syndrome related risk factors contributed substantially to risk of myocardial infarction, somewhat greater associations in women compared to men, especially for hypertension and diabetes. There was a stronger association in women, and also exercise was more protective for myocardial infarction in women. So, as already mentioned, there are clear biological differences between females and males, and males at younger age have a more adverse risk profile and therefore higher cardiometabolic risk. There are the differences in body composition, glucose homeostasis, and lipid profile. For example, younger women have better insulin sensitivity, lower fasting levels of glucose, and overall lower prevalence of type 2 diabetes. It's also important to consider pre-diabetic stages, the impaired glucose tolerance state. And here it's very clear that at all ages, women have a higher prevalence of impaired glucose tolerance. And this pre-diabetic state is already associated with high cardiovascular risk and also higher mortality. So it's important, if you have young women with risk factors but normal fasting glucose, please consider to perform an oral glucose tolerance test. If we look at obesity, it's clear there's a kind of gender switch around the age of menopause with increasing rates of obesity in elder women. And in fact, menopause is a kind of game changer. Then the risk increases. It was already said in the first talk, visceral fat increases, and at the same time, bone and lean mass decreases, and therefore body mass index is not the ideal parameter to evaluate cardiometabolic risk, especially in postmenopausal women. It's very easy to measure waist circumference, a very simple parameter and the better predictor, especially in postmenopausal women, for evaluation of cardiometabolic risk. There are a lot of cardiometabolic risk factors, modifiable risk factors, which are of greater interest. Some have higher prevalence in one sex and more impact weight in the other sex. For example, if we look at psychosocial stress or depression, there is higher prevalence and greater weight in women. The same is true for low physical activity. On the other hand, smoking, for example, still higher prevalence at the global level in men, but more adverse effects in women. And of course, there are also non-modifiable risk factors, some related to prenatal life, fetal programming and birth weight, but also autoimmune diseases, rheumatic diseases, which also relate to higher cardiometabolic risk and are much more common in women. And then there is the big group of sex-specific risk factors with early menopause, PCOS, as a polycystic ovary syndrome, gestational diabetes, disorders in pregnancy or breast cancer treatment in men, erectile dysfunction, and low testosterone levels. And indeed, it's very important for the medical history to think about the pregnancy outcome and reproductive risk factors in women, because there's really now a high strength of evidence that all these pregnancy complications, especially hypertensive disorders during pregnancy, relate to atherosclerotic cardiovascular disease, but also for the hypertensive disorders to stroke and heart failure. And all the other pregnancy complications clearly relate to atherosclerotic cardiovascular disease. Gestational diabetes, for example, is the most common complication. 10 to 15% of all pregnant women will develop gestational diabetes. And these women have a very high risk of cardiovascular disease later on, even if they do not progress to overt diabetes in later life. So here, another big part, the dietary risks clearly relate to the number of deaths at the global level with some sex differences. In this big study, leading dietary risk factor for mortality in women was low intake of whole grains. In men, it was high intake of sodium, although high sodium intake in the total group is the biggest risk factor. And also other big analyses showed that cardiometabolic mortality associated with each of all these listed dietary factors was higher in men than in women. So overall, men have a more unhealthy lifestyle, more unhealthy dietary habits. And the largest sex differences are seen for processed meats and for sugar-sweetened beverages. In this study, the number one leading dietary risk factor was excess processed meats in males and excess sodium intake in females. What we also clearly know is that if we adhere to healthy nutrition, to Mediterranean diet or the DASH diet, then we can reduce incidence of cardiovascular disease. This has been shown in both sexes and for all ages. So the better the adherence, the lower is the incidence of cardiovascular disease. We have also very nice data from a lot of diabetes prevention trials, randomized controlled trials in men and women with impaired glucose tolerance or pre-diabetes mostly. And it was clearly shown lifestyle changes, increase of physical activity and healthy nutrition reduced diabetes risk by about 40 to 50%, induced weight loss. Some studies show greater weight reduction in men, and some also show greater improvement of insulin sensitivity or triglycerides in men. But we have to bear in mind that in all these studies, men usually have higher physical activity, higher moderate physical activity, and women mostly low physical activity. So that's an important point. In weight management programs, the most participants are females, but men are more successful in reducing and maintaining weight. And there is also some evidence that sex-specific team sports-based intervention programs are very effective, especially for men, but probably also for women. For example, the football fans in training, a group-based weight management and healthy living program, which was started in UK and Scotland, and there are now many follow-up programs all over the world. It's cost-effective. Men love to participate. It's very important. They must have fun. It was clearly shown that life quality and risk of future ill health was reduced. And maybe it's also an idea for women, at least in Nordic countries, reported that long-term soccer training resulted in better health profile of untrained premenopausal women with mild hypertension. So that's also a possibility. I just want to share with you the results of the latest diabetes prevention study, the Chinese Daqin study with the longest term follow-up, 30 years now. 6 years was the intervention, and now 30 years later, we see that in the intervention group, it was only lifestyle intervention. There was lower incidence of diabetes, cardiovascular events, microvascular disease, cardiovascular deaths, and all-cause mortality. But after stratification, the data by sex, it was also seen that a significant reduction in cardiovascular events and all-cause mortality was only found in women. So it's probably exercise and healthy nutrition, but women would especially benefit from increasing physical activity. New data and also older data show that inferior control of LDL cholesterol in women may be the primary sex difference in modifiable cardiovascular risk, both in primary and in secondary prevention. It was women had lower LDL cholesterol assessment rates, but higher measured LDL cholesterol values. And in addition, the age-dependent increases in LDL cholesterol and HbA1c were greater in women. And also other recently published studies confirmed that women had smaller decreases in their LDL cholesterol than men in the last decades, and overall lower prevalence of controlled dyslipidemia, especially in primary prevention. But we have very clear guidelines and recommendations. We know how to treat. There are many drugs now on the market, and the treatment goals for LDL cholesterol are very clear for all the risk groups. So we just have to avoid clinical inertia and improve adherence to drug prescription. Just one study to prove that diabetes is really a very prominent risk factor, especially for women for cardiovascular disease. In this big data analysis, even after controlling for major vascular risk factors, doubled occlusive vascular mortality risk among men and tripled the risk among women. And if we look at the younger women, younger than 60 years, then the increase of risk in women was even greater. So it's very important to avoid or treat diabetes as good as possible. And also here we have now new guidelines showing that all subjects, all patients, men and women at risk or with established cardiovascular disease should be prescribed the classes of drugs that have shown, that have proven cardiovascular disease benefit. That's GLP-1 receptor analoga and SGLT2 inhibitors. But real world data still show that this is not the reality, that these drugs are prescribed in the subjects who need it. And this slide just shows that indeed, if we do pooled analysis, we see that the GLP-1 receptor analoga and the SGLT2 inhibitors reduce in some studies even mortality in the data in the cardiovascular outcome trials. And at last, just mentioning that gender is also important. It's complicated to measure, but it's a psychosocial cultural construct composite measure of that we tried to evaluate in this study in Canada and in Austria. And what we saw is that the female sex was related to low risk of cardiovascular disease and a better cardiovascular health index. On the other hand, high gender scores, which are related to female characteristics, personality traits, behavior, were related to bad cardiovascular health index and a higher incidence of cardiovascular events. So it's not only the sex, it's also gender, but it's not easy to measure it. We have to develop measurement. So to summarize, we have to assess, treat to target, that's important, and monitor glucose, LDL cholesterol, and blood pressure in both men and women. Healthy lifestyle has to be promoted, probably physical activity, especially for men, and healthful activity, especially for women, and healthful nutrition, especially for men. Sodium intake should be reduced in everyone. Promotion of resilience, reduction of stress if possible, maybe more emotional stress reduction for women and physical stress reduction for men, and related to gender, the gender scores also promoting gender equity should have an effect on cardiovascular risk and disease. Maybe we need new sex-specific biomarkers or sex-specific cutoffs of the traditional ones, or even sex-specific risk scores who do better. So thank you.
Thank you so much for this complete overview. Just to keep the schedule that it's very tight, I just read one of our colleagues in the audience asking, is there a difference in the cardiovascular improvement after bariatric surgery between women and men? Please, Alexandra, very short.
Yeah, that's a very good question. 80% of bariatric surgery patients are females. Also men also need it, but that's the reality. And it was shown that women have greater reduction in cardiovascular risk following bariatric surgery because mortality in males is still somewhat higher than in females following bariatric surgery. The reason is not completely clear, maybe because it's 80% females, the other way around, the other Yentl syndrome. In this case, we have more females that undergo this procedure. I don't know, but it's favorable for both sexes. That's very clear. But now we also have good drugs, pharmacologically to reduce weight with the new GLP-1 analogs and also dual therapies, which will come on the market very soon, where we also can reduce weight dramatically.
Thank you so much. And now it's the time to move to the next speaker. It's my pleasure to introduce Professor Karolina Kublikene, and she comes from Karolinska Institute, Division of Renal Medicine, Stockholm, Sweden. And the title of her talk is Sex and Gender, Hypertension, Inflammation and Aging, Cardiovascular Effects of Androgen and Estrogen. Please, Karolina.
Thank you very much. Very pleased to be here. So, first of all, I would like to give a compliment for the society because it's a really excellent timing for the Horizon Europe applications, where indeed the gender dimension should be appreciated in the JEP as the eligibility criteria. And what I mean with the gender dimension that we listened before is actually appreciating sex as the biological variable together with the gender construct that together of them could also modulate the health, disease and medicine. And today I will support the suggestion that cardiovascular disease is sex and gender sensitive, and I will elaborate on the conditions related to reproductive health and primarily to pregnancy-induced hypertension followed with the menopause. So what is preeclampsia? Preeclampsia is a hypertensive pregnancy disorder that occurs in 2 to 8% of pregnancies and is defined as new onset of hypertension and new onset of end organ damage after 20 weeks of gestation. Severe forms may include eclampsia and followed up with the HELP syndrome. 70 million women worldwide is affected per year, and a quarter of the babies born to mothers with preeclampsia are growth restricted, and a third are premature. This is an important condition, and we need to address that. This is a simplified pathophysiology of preeclampsia, which includes 2 stages. The first stage is actually associated with the reduced placental perfusion or impaired placentation in the presence, of course, of the mother's maternal risk factors, which is combined. And of course, impaired placentation is associated with the hypoxia and release of placental factors, including soluble fluid, soluble endoglins, cytokines, Ross placental debris to maternal circulation, and the development of the stage 2 maternal syndrome with hypertension affecting major organs. As we know now, the preeclampsia is the small arteries disease, and preeclampsia targets maternal endothelium. As an example, here you could see a very simple picture of the changes in endothelial morphology in the woman with preeclampsia where we got the vessel on the C-section in comparison with the nice endothelium present in the arteries from women with a normal pregnancy. And of course, this accompanied with the changes in the functional properties with the pronounced endothelium-dependent dilatation in arteries from normal pregnant women, and indeed flow-mediated constriction in women with preeclampsia due to the abnormal contribution of endothelium-derived factors and increased contribution of, for example, endothelin-1, which is constrictor factor. As mentioned before, preeclampsia is a serious condition and really affecting premenopausal women in respect to cardiovascular risk. And what is important here, that indeed the severe preeclampsia, which shows the early onset with small for gestational age baby or preterm infant or recurrent preeclampsia, dramatically increase the risk for hypertension, cardiovascular disease, stroke, thromboembolism, and stage kidney disease, and even mortality. So this is important to know because we in the scientific community trying to understand the underlying mechanistic links between the history of preeclampsia and cardiovascular disease, which could be a key step for targeting therapies to maintain cardiovascular health. With that, I would like to present our recent study in the vascular health after preeclampsia, where indeed we looked at the resistance artery structure and function between the woman with a history of early onset severe preeclampsia versus woman with a history of normal pregnancy 2 years postpartum, when the woman donated for us the fat biopsies and we used the isolated small artery biopsies to assess functional and structural properties. And the major finding here is showing here that you see that woman with the history of early onset of preeclampsia has significantly reduced flow-mediated dilatation in comparison with the woman that had the normal pregnancy. And of course, the flow-mediated dilatation in the control woman is mediated by nitric oxide, whether the nitric oxide contribution is absent in the woman with history of early onset of preeclampsia. And considering the fact that the eNOS is actually expression is preserved together with the responses to bradykinin and SMP, we believe that there is a possible problems in the impairment of flow detection and signaling. In addition, in respect of the hypertension, we also show that 2 years after the preeclampsia, we see the increase in the myogenic tone, which is significantly different with the myogenic tone in the arteries from women with a normal history of normal pregnancy, which together with the increased sensitivity to norepinephrine in the arteries from women with a history of preeclampsia suggest that indeed there is the optimal prerequisite for the increased risk for developed preeclampsia, hypertension, And of course, you know, the woman with a history of preeclampsia also show the reduced sensibility, which is associated with in the longer term, with increased arterial stiffness. What is important here, and with respect to the cellular senescence and vascular aging, we already see in the vessels from those young women increased expression of the senescence marker like P21 in these vessels as well, and the reduced expression of NRF2 factor, which is really known as a transcription factor for the antioxidative stress response, and its relation to activation of the variety of the cytoprotective genes related to the redox and detoxification, as well as increased TNF-alpha expression. What this means that indeed there is so-called senescence-associated senescence phenotype, which indeed SAS phenotype, which affects surrounding cells and damage tissue function and even preserves or increase inflammation. And therefore, I really want to stress that potential treatment using the senolytic drugs, which are targeting senescence-associated anti-apoptotic pathways to induce the senescent cell clearance and to preserve tissue maintenance. To summarizing this part, I think I convinced you that indeed, as you all know, history of preeclampsia is recognized risk factor. And of course, I showed for you even the functional and structural abnormalities which exist 2 years postpartum, which could be associated with the increased risk for hypertension and cardiovascular disease. And I truly believe that together with the whole community, we have to develop the strategies for prevention, screening schedules, clinical targets, and treatment regimes. This is extremely important. The second part is related to bringing estrogen back to cardiovascular health. When shall we complete the puzzle? And I think also in this community, this is not a secret that loss of endogenous estrogen facilitates the development of hypertension. And this is what we know, that early onset of menopause is associated with the increase in blood pressure. Hypoestrogenic premenopausal women like PCOS have increased risk for hypertension. And we also note that the blood pressure increased dramatically within few weeks after surgically induced menopause. Why this is happening? And here also I'm very pleased to present our study where we assess the small artery function from the peripheral circulation, and you can see that flow-mediated dilatation is significantly reduced in postmenopausal women in comparison with the premenopausal woman, as well as endothelium-dependent dilatation to bradykinin is also reduced in postmenopausal woman, and accompanied with the disturbances and morphology and endothelial cell layer. The good thing is also that 17-beta estradiol upregulates after prolonged incubation the flow-mediated dilatation, and this occurs via the nitric oxide. Important here also to stress that the effects are mediated by estrogen receptor alpha. Indeed, this receptor is predominant in this vascular system. And of course, I will discuss later the importance of those receptors for the vascular maintenance. So this is the summary slide for the all beneficial effects that 17-beta estradiol has. And for those working in the field, we all can share this classical picture about the rapid effects and long-term effects affecting atherosclerosis and vascular maintenance. And here also I listed additional features related to the regulation of the oxidative environment, distensibility, cellular adhesion molecules, EPC's mobilization and function, and of course post-translational action of estrogens regulating the majority of physiological mechanisms. So why we have been shocked 2002 when the Women Health Initiative trial was prematurely stopped. And of course, the conclusion was that the menopausal hormonal therapy should not be used to prevent cardiovascular disease in postmenopausal women. And the estrogen only arm was stopped 1 year later with the condition primum non nocere is important, but translation into core vadis is even more essential. And I think today in this conference, we really have to learn and to understand where to go from here and what is the difference between the observational experimental studies versus randomized clinical trial that I showed for you previously. And indeed, I'm trying to list you the most important points here, that indeed we have to appreciate the menopausal condition per se and vascular function in the postmenopausal woman in the presence of the risk factors. And the second important thing is to understand the timing or window of opportunity hypothesis when the hormonal therapy should be initiated. And indeed, we have quite an important differences between the observational studies initiation of the 7 years and Women Health Initiative 14 years. Also, the type of estrogen used for the hormonal replacement therapy and the mode of usage, transdermal or oral, because, for example, in CEs like Premarin is a mixture of estrogen extracted from the horse urine and contain progestins, androgens, and other substances. Role of progestin, which is actually varying degrees of androgenic and glucocorticoid activities. As I mentioned, we need to understand distribution and function of estrogen receptors in the vasculature and the other important cardiovascular system organs, as well as estrogen receptor gene polymorphism and other genetic mutations that could be associated with the adverse effects related to the menopausal hormonal therapy. This is for the support for the timing and natural estrogen administration. And you can see in this cartoon that transdermal estrogen application improve flow-mediated dilatation in the younger postmenopausal woman. And of course, also our own study where we performed the randomized clinical trial to compare resistance small artery function and the responses to intraluminal flow before and after 3 months supplementation with the 17-beta estradiol. You see the upregulation also in the presence of MPA, where the MPA alone has no effect on the flow-mediated dilatation as well as the placebo. For those who are interested, the support for this also comes for the KIEVS trial and ELITE trial that I'm not going to touch upon. So to sum up this part and to bring together, I want to stress that indeed menopausal symptoms will affect quality of life and will modulate cardiovascular risk. And indeed, hormonal therapy is the most effective treatment for amelioration of vasomotor symptoms and problems related to genitourinary syndrome. Indeed, what we can suggest that hormonal therapy earlier after menopause and using low dose of estrogen or transdermal hormonal therapy at the lowest feasible doses and shortest duration time is applicable. However, we should work together and to assess individual cardiovascular risk and discuss the quality of life and long-term follow-up. I am finishing now, but I have to apologize because of the time and this very challenging title that I've got from the organizing committee. I'm happy to talk about the androgens next time, but for those who are interested, I am putting, the important studies which are related to the endogenous testosterone and cardiovascular risk. And with that, I am very pleased, and I would like to thank my university. I would like to thank my colleagues that are working together at the cardiorenal lab as the PIs, as Professor Magnus Beck and Professor Peter Stenwinkel. I would like, to thank the funding agencies. And mostly importantly, I would like to thank you for the listening. Thank you.
It's tight. It's a challenge, and it would be fantastic to talk for hours. I just want to read for you a question from the audience, but please just give me a short answer. So the association of preeclampsia with molecular changes in P21 and NRF2 are very interesting. Do you have any idea about the driving mechanism? Do you think these pathways are changed before preeclampsia or are a consequence of preeclampsia? What do you think comes first?
To my understanding, at least, for early onset of preeclampsia, I truly believe that this is the consequence of preeclampsia because of this stressful situation during the preeclampsia per se. But of course, we're working for that, and this is extremely important question. Thank you.
Thank you so much. You can also, in case, answer to the question in the chat. Because now I need to move on to the next speaker. I welcome Hester den Reuter from the Laboratory of Experimental Cardiology, University Medical Center Utrecht, the Netherlands. And she will talk about gender and sex aspects in atherosclerosis. Please, Hester, we are looking forward to hear your presentation.
Much. It's a
Thank you
to be here. I'll try to share my screen. I hope this works. I hope you can see my screen now.
We see you at the moment.
Well, the program says my screen is shared, so.
Now we see it. Now it's great.
Yes, you see it. Okay, so I'd like to thank the organizers for having me today. It's really exciting to have all these topics brought together, so thank you very much. I'll talk a bit about atherosclerosis, and I think most of you are well known with this classical image of a man, grabbing his chest because of the chest pain caused by atherosclerosis, which you can see on the right side, which is a major cause of cardiovascular disease. And as was already mentioned before, atherosclerosis develops over time, but we see interesting sex differences in the mechanisms causing the final occlusion. So when we talk about obstructive coronary artery disease, it was already described in the 1990s that plaque erosion was more common in younger women, which we see here on the left side, which actually means that there's a thrombus occluding the artery on top of a stable non-ruptured plaque. And it was more common in younger women, specifically premenopausal. And plaque rupture was more seen in men who died of a myocardial infarction, which you can see to the right. So you can actually see that the plaque itself has ruptured from the inside out, causing the occlusion. And this coincides what we have seen also in other vascular beds where women tend to develop more stable plaques, which are rich in smooth muscle cells and collagens, whereas men more often tend to develop the unstable plaque phenotypes, consisting of large lipid pools, plaque hemorrhaging, and inflammatory cells mostly. And we asked ourselves, so what are the reasons that we see these sex differences in the plaque composition between men and women? And are there sex differences in the molecular networks that are driving atherosclerosis? And our second question was, can we identify female-specific mechanisms or key driver genes that are responsible for symptomatic stable plaques and plaque erosion? So for this, we collaborated with the group of Professor Johan Björkgren in Mount Sinai, New York. He also works in Karolinska Institute, and he had initiated the StarNet biobank, consisting of 600 patients that underwent coronary artery bypass graft. And during the procedure, 7 tissues were, biopsies were taken from 7 different tissues, among which aortic root biopsies with atherosclerosis and the memory artery used for the procedure, which is non-atherosclerotic by definition. And we contacted Johan because we knew that he'd already described these gene regulatory networks of atherosclerotic disease before. However, he did not do any sex stratification. So one of my PhD students actually went to the lab of Johan in New York, Robin Hartman. He's now a postdoc in my group. And he did a very simple first analysis. So he selected the 160 women that were in the biobank, less than the men, and age matched these 160 women to 160 men. And he actually looked at gene expression patterns, which you see here on the left side, where you see the number of genes of the aortic atherosclerotic root, that where the RNA expression was determined. And he first analyzed 160 expression patterns of these plaques of these women. And then he started doing an analysis using 160 women and no men, which is completely to the left side. And then he analyzed 159 women, 1 man, 158 women, 2 men. And then he moved sort of these patterns of these genes to the right side, where you can see the gene connectivity of 100% men. And gene connectivity is actually a feature of genes that actually tells you how well they are co-expressed together. And it is thought that gene connectivity is, like gene expression, a characteristic of a gene that determines its functionality. You can clearly see that on the top right, when we look at the gene connectivity of 100% men, that you see this cluster in the top right panel that is still visible when you analyze 70% men and 30% women, which we normally tend to do in these type of analysis. However, when you look to the left side, you see a completely different cluster appearing in women, which we completely cannot see when we do the analysis using the 70-30% of the sexes. And when we looked a bit more in detail on the biology that was underlying this gene connectivity in women, we found mostly mesenchymal cells and endothelial cell biology, whereas in men we found mostly inflammatory cell biology. We moved forward and we started constructing key regulatory networks using the females only, based on the slide that I showed you before. So based on the clinical characteristics, we identified 3 large female networks, which you see here depicted in yellow, blue, and green-yellow. And we saw that these female networks actually pointed towards estrogen signaling and cell transitioning. And these key networks are actually controlled by key driver genes that are hierarchically more important for these networks to be functional compared to other more peripheral genes. So based on the sex specificity of these key driver genes, we selected genes that were more connected in women as compared to men, but were also more important for the atherosclerotic tissue compared to the healthy mammary artery tissue, which we used as a control. And we wanted to know what was the cellular origin of these key driver genes. So in which cell types of the plex are these genes expressed that are thought to be so important for female atherosclerosis? And for that, we used a data set consisting of single-cell RNA sequencing derived from fresh plex. So after taking the carotid plaque out of the patient, we isolate the single cells and used it for single-cell RNA sequencing. And what you can see in the plot in the top panel, you actually see these different cell clusters that point to different cell types. So for example, cluster 7, which you can see with the arrow on the top, actually points to an endothelial cell cluster. And we actually identified of these 3 major networks where we had the key driver genes, where these key driver genes were actually located and where they actually were functional. And we saw, and here on the left side, you can see the different cell types that we find back in these human plex. You can see the T cells and the macrophages, smooth muscle cells, endothelial cells, and the inflammatory cells, the B cells and the T cells. And we looked on the different key driver genes where these cells were mostly expressed and were more connected. We saw that the blue network and the blue key driver genes were more seen in the ACTA2 positive smooth muscle cells, whereas for the yellow female network, we saw that they were mostly expressed in the endothelial cells of the plaque. And the last one, the green yellow network, was actually expressed in the macrophages in the plaque. And we followed up the ACTA2 smooth muscle cell key driver genes because we could see that they were actually higher, that their module score was higher in the females compared to the males in the single cell RNA sequencing data. And to understand a bit more on what these key driver genes were actually doing within these smooth muscle cells of the atherosclerotic plaque, we collaborated with a group of Gary Owens and Katie Ostiani, who was actually studying the smooth muscle cells in atherosclerosis. And using their lineage tracing mice, we actually found that the female key driver genes that we found in the blue module were actually likely involved in a smooth muscle cell phenotype switching. That is a common mechanism in atherosclerosis. So with that, I would like to conclude by hoping to have shown you that these gene regulatory networks in atherosclerosis actually depend on the sex of the patient. And that by focusing only on female networks, that we uncover new biology of atherosclerosis, and hopefully we've identified key driver genes that are important for symptomatic stable plaques that we will follow up in our future studies. And I think we should have an increased emphasis on these sex stratified approaches when we analyze these multi-omics data sets. And I would like to, of course, thank my collaborators for this work, and of course the funding agency that have made this possible. Thank you.
Thank you so much. It's so exciting to see this new data coming from your work. Congratulations. I would really like to ask you, for instance, which are the next steps? Just shortly, also because Paul wants to ask you a question. So what is next now to characterize, for instance, these differential cells based on sex?
Yeah, so one of my PhD students, Michael Bueno, he actually was able to culture plaques, so the cells actually from fresh plaques, which seem to be smooth muscle cell-like cells that sort of grow out of the plaques. And of course, we want to understand a bit more in detail what happens if we would intervene or knock down or overexpress these key driver genes, and see if we can truly identify whether these are, important for the network within the cell, and whether we can target them hopefully in the future to prevent this smooth muscle cell transitioning.
Thank you so much. Paul, short questions.
Yeah, thanks, Hester. Really great talk. I was interested in the enriched NDMT in women. We know NDMT is driven by TGF, by low shear and other factors. What in female patients?
Yeah, that's an interesting question. So I think that has to do with the estrogen signaling, and actually in all the bioinformatics analysis that we do, we sort of see this TGF beta signaling as being really sex dependent. So that's definitely interesting to understand a bit more. And what is fascinating is that we saw this estrogen signaling, and these women are on average 70 years old. So that means that there's some longer signaling within these plaques, even though the circulating estrogens are not there anymore.
Thank you.
Thank you so much. And the very last, please, also your short question. Do you see a difference in gene expression in patients taking statins, for instance?
Yeah, that's an interesting question. I don't think we looked at that, but I can imagine that most of these patients are on statins when they undergo this surgery. So that might not be the best cohort, but indeed within the ATRO-Express study, where we actually look at the carotid plaques, we could definitely look at that, whether there's sex differences within that. That's a great suggestion. Thank you.
Thank you for the colleague from the audience. Very good question indeed. And now, thank you, Hester. We move on. We fixed the technical problem. Sorry for the inconvenience. And now it's the time and my pleasure to introduce Professor Vera Regic-Zagrozek. She comes from the Charité Berlin, and she will talk us about section basic research. Please, Vera, welcome.
Okay. I hope you now can all see my screen, and I would give some ideas on the general concepts of sex and gender differences, and on studying sex differences in basic research. Usually what you do in this case, you observe a sex difference, either in human tissues, in animals, or in cell culture. And then you would like to know what could be the mechanisms behind. This could be genetic, it could be sex hormones, organizational effects, I will talk on this, or direct acute effect of sex hormones. And you have to consider all these mechanisms to make your hypothesis. Then you can decide what functions you want to study to see if your mechanisms affect more cells, organ function, or the whole animal, the whole person. When you are developing your essay, you have to be very careful because sex and gender usually interact with strain, with age, with the environment. There are good interaction where changes in food or in stress level changed the physiology of males, but not of females. And then you have to see what kind of readout you want, and modern omic technologies is offering a lot of new toolkits. So a lot of work in study planning. Let me go through these mechanistic possibilities first, and briefly discuss what kind of sex-linked differences can be due to sex chromosomes. You know, males have an X and a Y, and the pseudo-autosomal region of the Y is identical with the same region of the X. Females have 2 X chromosomes and are supposed to inactivate one of them, and this occurs only in incomplete manner. So at the level of sex chromosomes, women and men differ first by the Y chromosomal genes, then by the X dosage. 15 to 20% of X genes escape inactivation and are duplicated in females. Then X imprinting is important. Women inherit 1 X from the father and 1 from the mother. They are a mosaic, whereas men only have maternal X chromosomes. This makes, again, a difference. So what other possibilities of sex-specific gene expression? If we have differently methylated genes inherited from father or mother, and we now have a sex hormone or that activates a sex hormone receptor. Sex hormone receptors are DNA binding proteins. Estrogen receptors, androgen receptors, they bind to the DNA, and if they find a different methylation or acetylation structure, then this will lead to sex-specific differences in gene expression in the first place. In the second place, these sex hormone receptors can attract other enzymes, acetylases, methylases, to the DNA, and these can induce long-lasting sex-specific changes in the DNA and histones. And these are long-lasting epigenetic changes that persist at least during lifetimes. Complicated, but I think you have to be aware of this for planning experiments. I will show you an example where estrogen acts differently in male and female cells. We found in earlier studies that in female cells, estrogen decreases collagen synthesis, whereas in male fibroblasts, estrogen increases collagen synthesis. And this was mediated through different estrogen receptors. In females, this was due to estrogen receptor alpha, and in males to estrogen receptor beta. So we try to understand what leads to these sex-specific effects on collagen synthesis. And indeed, we found that the estrogen receptors are differently phosphorylated in the female and in the male cells. Estrogen receptor Alpha is more phosphorylated in the female cells, beta is more phosphorylated in the male cells. And phosphorylation determines how estrogen receptors bind to the DNA. And we therefore studied DNA binding of estrogen receptors and found that there is much more estrogen receptor binding to the DNA alpha, estrogen receptor alpha binding to the collagen promoter in females, and that this is different from the male cells. In the male cells, there is also a stronger binding of estrogen receptor beta. This is a complicated story published in Cardiovascular Research in 2018. If you put it together, then you get a message that fibrosis or collagen synthesis is activated by estrogen, either in males or in old women, and come to this in a minute. Estrogen binds to the DNA, and in the male collagen promoter, an dimer of estrogen receptor beta binds and activates fibrosis. In the female DNA, estrogen receptor alpha and beta are binding as a heteromer and are inhibiting collagen deposition. So this actually leads to a lower collagen deposition and fibrosis in the female heart, as long as the female is young. In older age, we have some other changes that lead to more pro-fibrotic mechanisms, and these modify the action of estrogen. They inhibit the collagen degradation, and this leads to the fact that in old women, we have more fibrosis. In young women, we have an activation of fibrosis in men by estrogen and an inhibition of fibrosis by women, but in old women, we do again have an activation of fibrosis. Aging interferes with the action of sex hormone at many levels, and we published this in 2020 in Aging. Aging modifies the nuclear expression of sirtuins, enzymes that modify DNA. It changes the activity of mitochondria and activity of inflammatory cells of macrophages, all with the interaction of estrogen. What we also see is that mitochondria, the energy generating points of the cells, are heavily affected by estrogen. Estrogen modifies cyclic AMP generation in mitochondria, what is important for the regulation of their energy output. Aging again, through carbonic anhydrase and some acetylases, affect cyclic AMP content in a different way and also modifies energy metabolism. So we do have again an interaction between estrogen and aging. This is also important when you look at beta-adrenergic signaling. Estrogen affects adrenergic signaling at different levels, modifying receptor expression, modifying cyclic AMP, and modifying calcium release. And it also can modify MAP kinase activity and L-type calcium channel. So there is a lot of literature on this. Just keep in mind that estrogen heavily interacts with adrenergic signaling and thereby modifies a number of pathways in the cells. And last but not least, sexual hormones, estrogen and androgens, interact with cardiac stress and drive pro-inflammatory responses in different pathways in males and in females. And this occurs by action on macrophages And by modifying the macrophage phenotype to M1 macrophages, or in females to M2 macrophages, what leads to more immune regulation and wound healing, whereas in men we have more active inflammatory reactions and chronification and fibrosis. This was a very brief summary of the mechanisms that you have to keep in mind when you want to study sex differences and effects of sex hormones. When it comes to readouts, I mentioned the multiple omics approach possibilities that we now have. And something that is very important, what we are now learning on the proteome is it's completely the proteins that are activated in a disease really differ in males and in females. This is very general. And the changes in the proteomes are not always predicted by changes in the transcriptome. So if we identify changes in gene regulation in messenger RNA, you have to keep in mind that this is not one-to-one translated into changes in the proteome. And the proteome is closer to function than the transcriptome. This makes the study even more complex. I tried to summarize the sex differences as we know it now in a recent review with Eva Gertz. We put together a number of metabolisms that are different in male and female myocardium. This is energy metabolism, peroxisomal metabolism, regulation of MYLIP that can affect contractility. It's fibroblast collagen synthesis. It is also some anti-arrhythmia or pro-arrhythmic mechanisms that I could not discuss, but are explained in the paper. There is a lot of differences in the regulation of mitochondrial function and in the interaction with aging. And finally, we have always to be aware that macrophage activation and inflammation occurs in a highly sex-specific manner. This makes a very complex picture, and to get good results, it's very important to focus really on the mechanism that you want to study and to select the appropriate readout for your study. With this, I would like to thank my experimental group and all my collaborators that helped us, and also the funding agencies that helped us to get to the results. Thank you very much for your attention.
Thank you so much, Vera. It's always so interesting to look into details. I know that there is already one question. Marie-Luce, please.
Yes, thank you. Thank you so much for the great presentation. So you observe this difference between collagen expression between men and women. Do you have any data regarding, for example, wound healing in women compared to men?
We have some, no, not really wound healing. We have some effects that estrogen stimulates the viability of endothelial cells, and also the activity, the moving activity of fibroblasts in culture. This would be a prerequisite for wound healing, but it's not wound healing itself. We do it in a petri dish. We take a scalpel and set a wound, and then the the activity of the fibroblasts that are moving into the damaged area is greater in the female cells, and it's stimulated by estrogen.
So what you observe could be applicable to other type of fibroblasts?
Yes, that's what we think. We observe it, yeah.
Okay, thank you.
Thank you.
Thank you.
Thank you very much. And now, in interest of time, we have to move on. Thank you, Vera. And now it's the time to introduce Professor Jolanda Wenzel, and she comes from the Erasmus University, Rotterdam, the Netherlands, and she will give us an overview on gender and hemodynamics. Thank you, Jolanda, please.
So in this session, we touched upon a number of differences observed in the manifestation and risk of cardiovascular disease among. So during those discussions, we did not factor in that hemodynamics are one of the key factors in localizing atherosclerosis. And we know that plaques are often observed in the inner curvature or close to side branches. We know that we really, that's one of the factors that we really have to think about. So next slide, please. So what is shear stress? Here you see a cartoon of a straight tube where blood is flowing. And normally in the center of such a tube, the velocities are the highest, and close to the wall, the gradient of the velocities are the highest, and that also represents the frictional forces of the blood at the vessel wall if you multiply it by the viscosity. Next, please. We know that shear stress and the endothelial cells are, we know that the endothelial cells are very sensitive to this shear force, and that they even align in the direction of the shear stress. If the shear stress is low, or even oscillating, they have a different morphology. And if this morphology changes, then also these endothelial cells have a different function. So in low shear stress areas, we know that the endothelial cells are dysfunctional and create a pro-atherogenic environment. So next slide, please. So what are the determinants of shear stress? First of all, that's the flow. And so the flow, you can imagine if the flow goes higher, then this gradient will be higher close to the vessel wall, and the shear stresses will be higher. Next. Also the viscosity of the blood, as I already said before. And then the last one, next please. We also know that the geometry is very much involved in the local shear stresses. You see an example of a carotid artery that is visualized by MRI, and in the different colors you see the different velocities in this carotid artery. And close to the bulbus you see that the velocities are low, and also the shear stresses are low, which is depicted by the green arrows. And so you see that in the low velocity regions the shear stress is low, and in the high velocity regions also the shear stress is very high. So these three determinants of the shear stress are important if we consider shear stress as one of the factors involved in atherosclerosis. So next one. So now if we want to unravel more the role of shear stress in cardiovascular disease, or even trying to understand why maybe women do different in terms of atherosclerotic plaque formation, we might think of the following questions. Is the shear stress and the shear stress distribution different in men versus women? And maybe because of the difference in local geometry. Would that maybe explain the differences in plaque load and or even distribution among men and women? And is there maybe somehow an interplay between female sex hormones and shear stress related plaque progression? Next, please. And so I looked into the literature first to check whether there are studies that actually looked into differences between men and women in terms of geometry. And this study by the group of Michiel Bots, they checked whether the geometry based on angiography was different. And so they took more than 2,000 or almost 3,000 angiograms of the ECST trial from patients that had a stenosis less than 50%. They had around 2,000 men and almost 1,000 women. they looked into parameters that are known to be related to, let's say, shear stress disturbance, if you will, but also low shear stress regions, and especially the diameter of the bulbus versus the diameter of the common carotid artery is sort of known to be, let's say, predictive for low shear stress regions in the carotid arteries. And so what did they found? Here you see an example of their data. They have angiograms of men and women. An example here is on the left side. You see that the ICA and the ECA are similar in size, but in men you also see often that the outflow area, so the area of the ICA plus the ECA versus the area of the common carotid artery, is actually smaller. So the outflow area is smaller than the inflow area. For women, they saw something else, that the ICA is often bigger than the ECA. And also they noticed that the outflow area in women is sometimes higher than the inflow area. So if they summarize, and next slide, please. They had an overview created. And maybe this is a bit of a complicated slide, but what it represents is that men have much more often a low ICA over CCA compared to women, and women show more often higher ICA versus the CCA. And so if you also check the outflow areas, as I already showed in the earlier slide, then also men show more often lower outflow areas compared to women. So next slide, please. Oh yeah, so what they also noticed, and this is what I already said, is that this diameter of the bifurcation versus the CCA is more, let's say, of an indication for the low shear stress exposure, and that was actually not so different in these patients. So next slide, please. And so what they also noticed is that if they check now the plaque distribution, it seemed that men more often have stenosis more distal from the bulbous region, whereas women show more often plaque in the ECA region, and also they have more often a stenosis in the external carotid artery. Next slide, please. So another study performed by B-mode ultrasound also studied the relationship between the geometry of the carotid arteries and the sex and the distribution. B-mode ultrasound is very well capable to check the plaque at different locations in the circumferential direction of the carotid artery. They took a cohort of 4 different studies, and they had around 3,000 patients. Next slide, please. And so what they noticed is that, and that's quite interesting, is that men and women do have the same, let's say, plaque distribution over the circumference. So they do show higher plaque thickness, but the distribution itself is very much the same. And if they stratified for the different age categories, they also noticed that you do see the same distribution, but only the plaque was thicker for the higher ages. So next slide, please. And so the same holds true for the bifurcation region, where again you do see this very particular pattern with more plaque at the far wall of the carotid artery in the bulbous region, whereas also for the different ages you see the same patterns, but only higher plaque thickness for the higher ages. Next slide, please. So then we thought, is indeed the geometry well enough to predict plaque progression, also to predict these differences between men and women? And then I went over to Harvard, bringing bring in Women's and Medical Center to the group of Professor Stone. He had a whole cohort of Asian coronary arteries where he studied the role of shear stress in plaque progression. So he started off with 500 patients and then had follow-up data of almost 300 men and 100 women. And then he also studied the shear stress and plaque progression over time. Next slide, please. And so he used angiography data plus IVUS information, so ultrasound, and there he checked next. And then he calculated the local shear stresses and compared the local wall thickness to the local shear stress. Next. Next. And so we also noticed, similar as the earlier speakers, is that men have more often larger plaques, whereas women has a more skewed distribution towards lower wall thicknesses. Next slide, please. So we checked the different vessel characteristics. So for all the different coronary arteries, we noticed that the lumen was smaller. We noticed that the plaque was smaller, but also the outer vessel wall boundaries were smaller. But actually that the plaque burden, so that is the ratio of the plaque area over the vessel area, was actually always similar for men and women. Next slide. And so what about the flow and the shear stress? We noticed that for women, there was a slightly lower flow in the coronary arteries, even though for the LCX even not significant, and the RCA, we did actually not see any difference, but the shear stresses were not different at all. So next slide, please. So what about the shear stress related plaque growth? We subdivided the shear stresses into 3 categories: low shear stress as being lower than 1 Pascal, high shear stress higher than 1.7 Pascal, and we noticed a clear inverse relationship between plaque growth and shear stress, but we didn't see any difference between men and women. So then we thought to explore the data a bit further. Next slide, please. We checked if we could stratify our patients into categories of age, and then we found these data. And now we took actually the shear stress as a continuous variable into our models. And we noticed that for younger women, this relationship seems to be much more inverse compared to the men. And then if the age was increasing, we noticed that these women, actually this relationship is changing quite a bit. Whereas for the men, this relationship was much more stable. This is really exploratory data, and please realize that we also have to correct for estrogen levels, which information we didn't have, because this is a retrospective study, and we really need further studies to explore this further. So next slide, please. So in summary, shear stress is an important determinant of endothelial function and thereby plaque initiation, progression, and we also know from other studies from plaque destabilization. Differences in geometry of the carotid arteries of men versus women are observed, but limited data is present. And hardly any difference in flow and shear stress was observed for men versus women in coronary arteries. Women show a large variability in shear stress-related plaque growth, and then also dependent on age. And men did not show really so much of an shear stress-related plaque progression over the age decades. So next slide, please. And so I have to acknowledge all the collaborators, and in particular the group of Professor Stone, who actually helped me to analyze these data. Thank you for your attention. I'm more than happy to take any questions.
Thank you so much, Yolanda. It's very stimulating. And actually, I allow myself for a very quick question. Your conclusion slide, point 4. Do you think there is a direct role for estrogen?
Yes, I really do see a direct role for estrogen. I think that estrogen, as they are very much involved in the endothelial function, as is shear stress. Shear stress is also a lot CSS also influences the local endothelial function. I think there could be really an interplay between those two. And I think we really need more basic science studies to figure out in which sense they interplay with each other and how they could even influence the local plaque progression.
Thank you so much. I would like to thank all the speakers, and now it's the time for Marie-Luce Bochaton-Piallat to give the closing remarks. Marie-Luce, please.
So we, on behalf of the Council on Basic Cardiovascular Science and the Working Group on Atherosclerosis and Vascular Biology, I would like to thank our speakers for their outstanding presentations and also for the great discussion. And I think it was very exciting to all of us. Thank you also to Paul and Elena for chairing the symposium. And many thanks also to the attendees for joining. We had over 100 attendees during the talks, and we received many interesting questions that reflect, I think, how important is the topic discussed tonight. So I would like, before closing the session, to present our working group. And I just would like to say that our working group includes many members, and the nucleus members are from clinical and fundamental scientists. And our main goal is to raise awareness on cutting-edge vascular biology research and its application to improve patient outcome. And we disseminate our messages through publications such as position papers, spotlight issue. We also participate in guidelines, and of course we participate in sessions for different ESC congress and congresses outside the ESC. And so please join our working group. Membership is free. You can apply for awards, and you can access to the webinar, symposia, receive our newsletter, and you can have discount on the ESC textbook of vascular biology. Ah, yes, so everything there. And with that, I look forward to meeting you, I hope, in person very soon. Have a nice evening. Goodbye. Thank you so much to everybody.
Bye. Bye. Bye.